Hey guys, welcome back to the channel. I'm Scott. Today's 10-minute medical recap, we're going to cover heart failure. We got a lot to dig into, cover this in 10 minutes. Let's get into it. Alright, so guys, we're back. We're going to discuss heart failure. So what's heart failure? Heart failure is the inability of the heart to pump out enough blood. It's decreased cardiac output from the heart, which leads to fluid in the lungs, which is left-sided heart failure, or fluid in the body, which is right-sided heart failure. So cardiac output being decreased basically is the amount of fluid blood pumped out to the body from the aorta. So this amount right here is decreased. So if you see the heart pumps, it pumps out a certain amount of blood. That's the stroke volume. That's decreased. So when you think of heart failure, think decreased cardiac output, decreased blood out to the body. Pump is bad, guys. The heart cannot pump out enough blood to meet metabolic demands of the body. There's two forms of dysfunction, okay? There's systolic dysfunction, which is dysfunction of contraction, and there's diastolic dysfunction, which is filling dysfunction. It means the heart can't fill enough. So moving on to dysfunction, we got systolic dysfunction. Again, the heart muscle is not able to contract properly to expel enough blood out to the body. Think, guys, decreased ability to contract, and you'll always think systolic dysfunction. The heart can't contract. You see this in damaged weak heart muscles like in the myocardial infarction, and destroyed in weak heart muscles such as in dilated cardiomyopathy. Think of Bugs Bunny. He's got weak muscles. He can't contract, right? So that's where you're going to see these two types of things. Then you're going to see in this diastolic dysfunction, right? You have the heart is not able to fill properly or completely expel enough blood because it's non-compliant, meaning that it's an overcrowded state, right? So think decreased ability to fill with blood. You see this in things like enlarged muscle, like hypertrophic cardiomyopathy, and you'll see it in non-compliant muscle, seen in restrictive pericarditis. Think of like amyloidosis, right? You get amyloid plaques in the muscle and it fills up. So I put this picture down here of the Simpsons, right? Think of overcrowded, right? There's not enough room in the chamber to fill up with enough blood, so there's less blood in the chamber. And that's what leads to it. Something else you're going to think about is the ejection fraction, right? So the amount of blood pumped out of the heart is the stroke volume. Stroke volume is measured by end diastolic volume subtracting end systolic volume equals stroke volume. In systolic dysfunction, you typically have less than 50% ejection fraction. That's a fraction of the blood that's pumped out of the heart during cardiac output. So if you see over here, we have end diastolic volume on the left side here, which looks like the left ventricle is filled up with a good amount of blood. You see in the right side of that, the end systolic volume, there's a fraction that's gone, right? That's the fraction that's pumped out. So if we see there's 110 mLs that was in beginning at end diastolic volume, and at end systolic volume after contraction there's 70 mLs left, that must mean that 40 mLs is the difference, which is the amount of blood that was the stroke volume pumped out of the heart during that contraction, right? So how do we figure out the ejection fraction? Just like this here. You take the stroke volume divided by end diastolic volume and you get 100, which was 110 mLs, I'm sorry. Multiply that by 100, I give you 36%. So 36% stroke volume or ejection fraction was pumped out of the heart. So you see that it's less than 50%. That's diastolic dysfunction. So think the heart can't contract strong enough to pump out enough blood. In diastolic dysfunction, you see it's typically less than or equal to 50%. And over here, you're going to see that end diastolic volume, you see that there's not as much blood in the heart this time as there was on the systolic side. And end systolic volume, you see that there's definitely a lot less blood than there was in end systolic volume on the left-hand side. So let's assume that there's 90 mLs of blood at the end of diastolic and diastolic volume, and there's 45 after contraction. Remember, it's not a contraction issue, it's a filling issue, so it's already filled. So it's already filled with less blood, guys. It's already filled with less blood. So as it contracts, which is not a contraction issue, it contracts strongly and it gets out half that volume. So if you do the math on this one, you see that there's 50% ejection fraction. So again, that's the difference. That's what you're looking for right there to determine ejection fraction. Heart failure, what are some of the causes? Well, let's look at right-sided heart failure. The number one cause of right-sided heart failure, guys, is left-sided heart failure. That's the number one cause of right-sided heart failure. Think pulmonary hypertension, right? Pulmonary hypertension is going to be caused by things like drugs and toxins, chronic obstructive pulmonary disease. You see that with COPDs, chronic bronchitis, fibrosis. You're going to think think pulmonary embolism. You want to think idiopathic and inherited things like HIV that are going to cause problems. Right-sided heart failure is commonly called cor pulmonale, right-sided heart failure. You're going to see, if you did a cardiac cath of the right side, a pressure greater than 25 millimeters of mercury, and that's basically right-sided heart failure. So causes of left-sided heart failure, right? So here's some of the causes of left-sided heart failure. Coronary artery disease with myocardial infarction. You get coronary artery disease. You see that the blood, the vessels get stenotic, they get clogged up with cholesterols and plaques, and you can't get enough blood to the heart, causing a heart attack, which damages the muscles itself. Dilated cardiomyopathy, dilated ventricles of the walls of the ventricles, right? The myocytes get destroyed, so you get a weak, flabby kind of heart that doesn't contract properly. Again, when you damage the heart muscles, you get contraction issues. It can't contract properly. And you're going to see dilated cardiomyopathy a lot in alcoholics. Keep that in mind. You see that a lot in alcoholism. But there's too much pressure that gets built up in the left ventricle with either any of the reasons, to be honest with you. But coronary artery disease, MIs, DCM, dilated cardiomyopathy, damage to the heart wall muscle causes dysfunction of contraction. Again, guys, I keep repeating that because there's a distinction between them. Hypertrophic obstructive cardiomyopathy, you see that there's inflammation or swelling, there's muscle growth in the ventricle, and it can't fill up with enough blood, right? If it's occupying space inside that ventricle, it's not going to be able to fill up with enough blood to pump out. Remember, it's not a contraction issue, it's a filling issue. You're going to see that in restrictive tongue-tied. Restrictive cardiomyopathy as well. It's not that there's not enough space, but the heart itself can't expand or stretch because of the stiffness of the ventricle wall. So if it can't expand and stretch to fill up enough blood, again, it's going to fill up with less volume. So when you think HCOM and restrictive pericarditis, think overgrowth of heart muscle or infiltration with, like I said, amyloid causing filling issues and compliance issues. Other causes of left-sided heart failure, think beriberi. These are high output failures, anemia, and hyperthyroidism. Beriberi, you want to think thiamine deficiency, right? So check blood alcohol levels. Other things that can cause it as of late is obesity. They think that because you have so much body weight and you're carrying so much body fat that your metabolic rate might be higher, or metabolic demand might be higher. Hypothyroidism and hyperthyroidism, again, can cause it. Drugs and toxic can cause it. Arrhythmias. You want to think arrhythmias. If someone's in like AFib or something like that, it's going to cause less blood to be pumped out. Now we're going to look at the pathophysiology of heart failure, right? Just a real quick pathophys thing here for you to look at. So first thing that happens is sympathetic nervous system kicks in, right? The blood volume's not meeting metabolic demand, so the kidneys get hypoperfused, thinking that, hey, we need more pressure, we need more volume. So the first thing that happens is your baroreceptors inside your carotid arteries and other vascular structures inside the body get turned on because of the decreased amount of volume, and that increases your heart rate and peripheral resistance. And that's just a short-term fix trying to compensate for the decreased amount of volume. Then the RAST system, renin-angiotensin-aldosterone system, kicks in, which is the big guy. And this again is the kidneys that get underperfused because of low volume coming out of the heart. The sympathetic nervous system acting peripherally to cause vasoconstriction, decreases pressure, blood flow as well. The kidney signal for fluid retention via the RAST system. It's basically this feedback system where you're going to hold on to sodium and water because the kidneys think that you're underperfused, but your kidneys think you're low volume, but you're not. You're really just underperfused, and it causes basically like a vicious cycle of holding on to sodium and water. Keep that in mind. That's going to help later. So what happens in the RAST system? Renin gets released from the kidneys because it gets underperfused. Renin goes into the vascular system. Into the vascular system, it converts angiotensinogen to angiotensin 1. Again, guys, remember the kidneys get underperfused. When they're underperfused, renin gets released into the vascular system. In the vascular system, renin floats around and it cleaves angiotensinogen to angiotensin 1. Again, angiotensin 1 then will float around the vascular system into the pulmonary circulation, where angiotensin 1 will be cleaved by angiotensin converting enzyme to angiotensin 2. This is the powerhouse, right? Angiotensin 2. Angiotensin 2 goes into the vasculature, causes vasoconstriction, as you see there, but it also floats around and goes into the pituitary region of the brain and releases ADH, antidiuretic hormone. Antidiuretic, remember, antidiuretic, you're not going to pee, you're going to hold on to fluid. Think adds H2O, that's how I remember that. It'll also act on the adrenal glands to release aldosterone. Aldosterone, think reabsorption of sodium and excretion of potassium, because that's exactly what's going to happen. This is all going to happen in the collecting ducts. So ADH is going to have water reabsorbed into the vascular compartment. Aldosterone is going to have sodium absorbed into the vascular compartment. It's going to increase volume, and potassium is going to be kicked out. So you want to make sure that when you check these people, you're checking for hypokalemia, because they are going to be or can be hypokalemic just based on the mechanism of action here. And that's just a quick synopsis, guys, of the pathophysiology. Again, I go kind of quick, but go back, rewind the video, watch it again, just to kind of get a little better handle on it if you like. But this is supposed to be quick reviews and stuff that we can go back and just kind of get the basic idea without getting too in depth. So moving on, we're going to look at the signs and symptoms. So on the left side of heart failure, you're going to see hypertension. You're going to see things that have to do with the lungs. Remember, it's not getting pumped out to the body, so it's backing up into the lungs. Pressure backs up. So it comes from the lungs into the left atria. It's going to back up into the lungs. You're going to see dyspnea, fatigue, because the blood's not getting out to the body to give enough energy to the muscles. You're going to see orthopnea, paroxysmal nocturnal dyspnea, cough. You're going to hear rails. The person's going to be shortness of breath, be short of breath. On the left side, or on the right side, I'm sorry, you're going to see things like jugular venous distension. Remember, it's backing up into the venous system from the right ventricle and the right atrium. You're going to see jugular venous distension. You're going to see liver congestion and possible ascites. You're going to see peripheral edema. They can both have chest pain or may not have chest pain. You don't see it a lot with chest pain, but they can both have chest pain. They can both have an S3 or S4 gallop as well. But yeah, just keep your eye on that. So moving on to labs and studies, things you want to do, right? You want to do a CBC, you want to check for anemia. Remember, high output failure, are they anemic? That's what you're looking for. You can even check to see if the white blood cell count high. Is there an infection? Is there a pneumonia on top of maybe a pulmonary effusion or congestion itself? You're going to do a chemistry, right? You're going to look for hypokalemia, the potassium gets peed out. You're going to look for elevated LFTs, remember, liver congestion, elevated BUN and creat, and a decreased GFR. Remember, the reason all this kicked off with the RAST system is because the kidneys were hypoperfused. They're not getting enough blood and perfusion, so they're trying to hold on to it because it feels like the body doesn't have enough. And you're going to check a TSH. Remember what I said, high output failure, hyperthyroidism, and then others can be hypothyroidism, can be low output causing decreased cardiac output to the heart. Thiamine, check for beriberi. I mean, check the thiamine. Are they thiamine deficient? Do a blood alcohol level. Are they chronic alcoholic, or have they been drinking a lot recently and binging? I mean, these are just ancillary studies you're going to think about. BMP, we didn't talk about this a lot. Brain natriuretic peptide is increased. So when you get a stretch in the heart muscle, when you get that stretch in the heart muscle, BMP gets released. It's a hormone that gets released from the heart muscle. And anything over 100 is indicative, but you're kind of looking more for like 500 plus. And that's what you're going to see. You're going to see like the increased BMP is going to be pretty indicative of heart failure. Now you can also check for atrial natriuretic peptide increase. That's supposed to be kind of like a negative feedback mechanism. As that floods the blood because of expansion of the atria, it's supposed to shut off the renin system. What happens is over the long term, it just kind of gets used to it and it doesn't work anymore. So BMP is going to be definitely your more accurate and more sensitive study for congestive heart failure. You're going to do a chest X-ray, right? You're going to check for curly V lines. You're going to check for pulmonary effusions, pulmonary edema, cardiomegaly, things like that, to see if anything else is going on. Or check for pneumonia. You're going to do an echocardiogram, which can tell you the cardiac wall size, the motion, the valve dysfunctions. It can also give you the ejection fraction, but that's going to be very important. That's key. Remember that, very important for the echocardiogram. Something simple you're going to do is EKG, right? Check for ischemia, check for MI, check for LVH. You might pretty much see a non-specific EKG, and that's fine as well. Guys, real quick, one of the things I forgot to add to the slide and the video was just do a cardiac workup. You're going to want to do a troponin as well, just to make sure they're not having any heart condition or heart attack that could be causing the congestive heart failure itself. But yeah, just do basically a cardiac workup plus the other labs I discussed, and you should be okay. Let's get into the meat of the course, heart failure treatment. This is last but not least. So the question is, how do we treat heart failure? There's a few ways to treat it. There's an emergency treatment or standard protocol treatment. The mnemonic I use for standard protocol treatment is BBDs. It stands for beta blockers, dilators, diuretics, and digoxin. Beta blockers can be cardioselective, so you want to make sure you're not going to have any pulmonary compromise or respiratory compromise when using them. So they're sometimes used, but not often. Dilators, you want to think your nitroglycerin, your hydralazine, your ACE inhibitors, they all help to dilate the vascular system, decreasing the pressure and preload and afterload on the system. Diuretics, right? These are the ones that are going to make you pee, so you're going to reduce the fluid retention. Hydrochlorothiazide, you have your loop diuretics, Lasix, furosemide, bumetanide. Keep an eye out for hypokalemia. And then digoxin. Digoxin, the toxin. Digoxin is usually or typically used for people with exercise intolerance. It helps the muscle of the heart contract more strongly. But you're also going to keep an eye out for digoxin toxin levels. So that's something you're going to need to monitor. Things you don't want to use are going to be things like, or you want to kind of refrain from, are going to be things like calcium channel blockers, right? Calcium channel blockers are more inotropic. They decrease the ability of the heart to contract properly, and you want to stay away from NSAIDs as they'll cause more vasoconstriction, which can cause increase in pressure as well. Hey, thanks for watching. Hope you got something out of it. If you did, hit that subscribe button below. Follow me for more. That's the second rendition of congestive heart failure, and there's more to come. Thanks again, guys.